So thank you very much indeed for coming to the conference today, Dirk, and for talking to us now. I was wondering if you could explain to us how risk adjustment's used in Germany at the moment.
Yes, well, unlike in the UK, in Germany we have a multi-payer system. So people choose a sickness fund, which is a kind of non-profit health insurer, and they get a coverage from that health insurer. So everybody chooses a health insurer, but these health insurers have to take everybody who comes.
Okay.
So they'll have a different risk mix depending on who comes to them, and they all have to take the same contribution from every person, so there's no risk weighting.
Right.
So if we didn't have a risk adjustment, the money a sickness fund would collect wouldn't be necessarily the money it needs to pay for the healthcare it provides. So we have a risk adjustment scheme between health insurers trying to level out the money they collect and the money they need for paying for the bills.
So the money is raised sort of centrally, is that right? And then
Both. We have a central health fund, so we have a payroll tax for healthcare. That money goes to a central fund and is paid out to the insurers by the risk adjustment scheme, so risk rated. So a sickness fund with many young and healthy people would get less per person than a sickness fund with many sick people and older people. If the money doesn't, if they don't get enough money from the central fund, they have the possibility to raise additional premium.
Okay.
And the idea is that the payroll tax is frozen, so it wasn't going to rise anymore if healthcare costs expand. So we'll have more and more additional premium in the future.
So obviously the German healthcare system, going back to Bismarck, one of the oldest in the world, if not the oldest, how long have you actually been using risk adjustment techniques in one form or another? Is that a relatively recent development?
Well, we started with risk adjustment in 1994. Before that, we had an allocation system. So you had no free choice of fund. You were allocated to a fund by your company or by the area where you lived to. Was a complicated formula which allocated people to the funds. And we had big differences in contribution rates between the funds, but there was no risk selection because people couldn't change. Then in 1996, we introduced free choice of sickness fund. And to complement that, 2 years earlier, in 1994, risk adjustment was introduced.
And I understand in the early days it was just risk adjustment on age and sex, is that right?
Age, sex and ability to work status.
And what, sorry?
Ability to work status.
Right.
So very basic factors, which was due to data possibilities at that time.
And then since then things have become more and more sophisticated, is that right?
Yes, we introduced a risk pool, a kind of reinsurance, government reinsurance scheme in 2003, and we also introduced disease management programs as a further risk adjustment. So enrollment of somebody with a chronic illness, for example for diabetes, in a program for diabetes was used as further risk adjustment, and since 2009 we have a diagnosis-based health status adjuster too.
And is that a risk adjustment formula that's been developed by the German government, or is it a commercial risk adjuster, or what?
Well, we had a beauty contest, looked at different models, and chose as basic model the HCC model.
The HCC?
HCC by Verisk Health from Boston, and adapted that for German use and developed a bit further. So we now have a pharmaceutical component in that model, and we had some major changes in the hierarchies.
Tell us a bit more about this beauty contest. How did that work?
Well, we had, at that time there was no central data, so we had a database provided by sickness funds with encounter data, claims data from all insured, and we ran different models, Baltimore HEG model and other models from the United States and the Dutch model on that data, and looked how they performed and decided for the best model.
And you chose the best model in terms of how well it was predicting the costs?
Yes, predictive ratios for groups and overall statistical performance.
Right. Have you encountered any challenges or problems with risk adjustment since it was introduced, this most recent model?
Well, I think one of the main challenges is data and data quality. And of course, with a diagnosis-based model, we have concerns about manipulation or gaming of the system. So we had reports of sickness funds trying to influence the diagnosis provided by physicians, And so we had to also implement further audits on that level to get control of that.
So by manipulation, what are you getting at there? Could you explain to the
Well,
audience?
well, for example, we had sickness funds going to physicians, office-based physicians, and saying, I need, more diagnosis, and they were prepared to pay, money on the table, which is illegal for physicians, giving better coding for that sickness fund.
So they would change their coding to make it look as if their population was sicker than it actually was, and as you said, that was illegal. Did people go to court over it, or?
Well, no, didn't go to court. But first of all, physicians complained a lot, so I think that backfired, and the regulation for sickness funds and audit possibilities for supervisory authorities were enhanced.
And you say you now audit for this kind of activity.
Yes.
Could you explain how that audit process works?
Well, we look at the data and compare the data and development of diagnosis numbers between sickness funds and in time series. And if we see anything we think could be strange, we have the possibility to go to sickness funds and audit them and see, where the data came from and if the process of the data provision has been with or without manipulation.
Right. And what would you say have been the major advantages of shifting to this more sophisticated form of risk adjustment?
Well, I think we had two problems with the basic risk adjustment system. The one was we had a very skewed competition on switchers. So those people who actually switched from one fund to another tend to be very young people, better educated people, and people with a very good risk status. So older people and people who are actually in hospital or in care at the moment, they don't have the mind to switch their fund. So we had a lot of funds actually going to the market with a very low contribution rate and trying to attract these switchers. So we had a risk segregation between sickness funds with low contribution rates, with very young and healthy people, and sickness funds with high contribution rates and very sick people. And to stop that was one reason. And another reason was provision of care for chronically ill. So we found that sickness funds are very reluctant to provide systematic and managed care for chronically ill, because in the moment they become attractive for chronically ill, they fear that maybe people with that disease know, oh, that's a sickness fund, I'll get good provision, so I'll change it to that fund. And the moment where the payments to the fund don't reflect the additional risks they have to take on by insuring these people, they won't do it. So that was another reason why we introduced it.
You mentioned earlier the beauty contest that was run in Germany to choose which risk adjustment model would be applied. Is that beauty contest going to be repeated in the future, or
No. We have our model.
Yeah.
So what we now have is an annual revision of the model. So every year we go through the model, all groups, all hierarchies, and try to improve the model.
But you won't be having another beauty contest where you look at models from across the market. You're going to stick with that.
It would be very difficult, because of course all models are, if we take the ACG model, it's an American model. So the first work you'd have to do to make it comparable with our model would be adapt that to German models. So I think you'd never have a chance using adapted German model, comparing it to something on the international market that hasn't been adapted.
Right. And where do you see risk adjustment going in Germany in the next few years? What do you think the major developments will be?
I think we'll be staying with the system we have now for some time. At the moment, we have a government which isn't so into risk adjustment, has a more skeptical view, so I don't think we'll have an expansion of risk adjustment. But I think in the long term, we're of course discussing about new risk adjusters, maybe procedures or things like that introduced into the system, and maybe a discussion if you can bring quality measures into a risk adjustment system.
You said that the current government's a bit more sceptical about risk adjustment. Do you want to tell us a bit more about that?
Well, basically, risk adjustment in Germany is a very political, difficult subject, because it means allocating money to sickness funds, and every change we do in the system, of course, changes financial positions of sickness funds. And a lot of sickness funds are politically well connected, so the losers, and every change has a loser, will try to lobby for stop of that changes. And I think the main difference, and we were talking about the Dutch model too. The Dutch come from a system where they had, complete no financial responsibilities in sickness funds, and started introducing financial responsibilities and risk adjustment at the same time. So risk adjustment somehow is, part of, introducing risk into the system. Germany comes from a system where all sickness funds were completely at risk for their expenditure without risk adjustment, and then started to introduce risk adjustment to complement competition.
So kind of the opposite way around.
It's the other way around, so coming from the other side. And that, I think, is politically more difficult, because sickness funds say, well, risk adjustment means subsidizing the less efficient sickness funds. But of course it isn't that. It's, subsidizing those funds that have to bear a higher risk than themselves, but that's very difficult to explain.